Picture of pitting edema from PICC catheter migrate complication. CLABSI associated with extended dwell catheters. Introduction. CLABSI identification in extended dwell catheters remains a diagnostic challenge due to inconsistent definitions among providers, reporting by percentage of infections, not by infections per 1,000 catheter days, variable insertion techniques, percutaneous cut-down, modified Seldinger, differences in care and maintenance protocols, common pathogens, coagulase-negative Staphylococcus, Candida species, signs and symptoms, highly variable, depending on gestational and postnatal age, may present as isolated or multisystemic symptoms. Infants often do not localize infection well, leading to diffuse presentation causes of colonization, skin flora migration from insertion site, catheter hub contamination, contamination during insertion, contaminated infusate, hematogenous seeding from distant infection, device-related factors, single versus multi-lumen catheter, fibrin sheath formation, thrombosis prevention strategies, strict hand hygiene, use of maximal sterile barriers during PICC insertion, maintain a dry, occlusive, sterile dressing, limit manipulation and system entries, use needleless connectors, employ sterile or clean technique during access and tubing changes, interventions and management, immediate PICC removal, reinsert after 24 to 48 hours if needed, antimicrobial therapy via catheter, attempt salvage, repeat cultures after 24 to 48 hours of appropriate treatment. If no improvement or infant deteriorates, remove catheter. Closing tip: CLABSI prevention is multifactorial. Success lies in standardized protocols, vigilant monitoring, and early intervention. Always weigh the risks of catheter salvage against the infant's clinical status. Pleural effusion hydrothorax hemothorax from PICC lines. Most reports describe its occurrence after the catheter has been indwelling for a while. Upper body insertions have a higher incidence over lower body insertions. Unilateral effusion is more common than bilateral effusion. Identification may be masked if pre-existing respiratory distress is present. If identified early, the infant may be relatively symptom-free. The predominance of symptoms will be respiratory in origin and may include tachypnea, oxygen desaturation, CO2 retention, respiratory acidosis, and diminished breath sounds over affected lung. Pleural effusion is a rare but serious complication of PICC placement. It results from fluid accumulation in the pleural space, often due to mechanical or chemical injury involving the catheter and surrounding vascular structures. Causes: vein perforation during insertion, subclavian brachiocephalic or superior vena cava (SVC) injury, erosion of vein wall from continuous contact with the catheter tip, especially with left-sided approach or malposition in SVC, infusion of hyperosmolar solutions, medications causing chemical irritation, Hirsch thrombosis, combination of chemical plus mechanical trauma, vein erosion and subsequent fluid leakage PICC tip malposition outside the superior vena cava, obstruction of thoracic or lymphatic duct by catheter or thrombus prevention, confirm catheter tip placement, ensure it lies parallel to the vena cava wall. Verify tip location radiographically post-insertion, and when symptoms arise, intervention steps. Immediately stop infusion through the PICC line. Obtain chest X-ray to confirm pleural effusion or catheter misplacement. Aspiration attempt via the catheter. If fluid aspirated resembles IV fluid, diagnosis is likely confirmed. Continue aspiration until fluid is removed if possible. If blood returned, still consider pleural effusion if other signs present. If unable to aspirate or condition worsens, thoracentesis may be required. Correct catheter position. Withdraw PICC to appropriate SVC location. Remove midclavicular catheters if needed. Monitor closely with repeat chest x-rays to check for reaccumulation. Final note, pleural effusion due to PICC is often preventable with careful technique and early recognition. Always monitor for respiratory changes post-insertion and maintain high suspicion if fluid balance or chest imaging is abnormal. Thank you all for your time, attention, and thoughtful participation today. As NICU RNs, you play a vital role in safeguarding some of our most fragile patients. Mastery of PICC line management isn't just about technical skill, it's about precision, vigilance, and a deep commitment to safety and outcomes. Whether you're inserting, maintaining, or troubleshooting a line, every decision you make can prevent complications, reduce infections, and ultimately save lives. Your expertise and consistency form the foundation of high-quality neonatal care. Now that we've reviewed the evidence-based theory and best practices, it's time to shift gears and apply what we've learned through hands-on training. Thank you all for your time, attention, and thoughtful participation today. As NICU nurses, you play a vital role in safeguarding some of our most fragile patients. Mastery of PICC line management isn't just about technical skill, it's about precision, vigilance, and a deep commitment to safety and outcomes. Whether you're inserting, maintaining, or troubleshooting a line, every decision you make can prevent complications, reduce infections, and ultimately save lives. Your expertise and consistency form the foundation of high-quality neonatal care. This concludes the lecture portion of our PICC Task Force workshop. Now that we've reviewed the evidence-based theory and best practices, it's time to shift gears and apply what we've learned through hands-on training. Let's transition into our didactic and simulation sessions, where we'll practice these critical skills in a controlled environment to build both competence and confidence.